So we're going to be talking about oxygenation and cardiovascular disorders. We're going to be talking about congenital heart disease, a lot about congenital heart disease, and then we're going to be talking about a few acquired cardiac disorders. And I know it seems silly, but it is very important for you to understand how blood goes through the heart, okay? And I know everyone's like, yeah, I know. But if I can't ask you blood that's pumped into the lungs, where does it come from? And you can't tell me right away the right ventricle, then you need to review that because you have to be able to tell me how blood pumps forward and pumps backward, okay? If you understand normal, you will be able to figure out the abnormal, especially when we're talking about congenital heart defects. So, to review, I know it seems silly, but you don't know how many people get to level 3 and 4 and can't tell me this. But deoxygenated blood, so blood that has all the oxygen's been used up by the tissues in the body, comes into the superior and inferior vena cava and heads to the right atrium and then to the right ventricle, heads on out to the pulmonary arteries to the lungs, and that's where it picks up blood. So remember last week where we were talking about, we talked about the alveoli, right? And we said that alongside the alveoli was the blood vessels. And it's sending that deoxygenated blood in and then picking up oxygen to send out to the body. That's what's happening right there, okay? So that's how those two systems tie together, because when that heart is pumping that deoxygenated blood to the lungs, it's passing it by all the alveoli to blow off CO2 and get O2, all right? So next, after it's picked up oxygen, it's going to come back to the left atrium and then the left ventricle, and it heads out to the aorta so that it can be pumped out to the body. All right? And then the body uses all the oxygen by sending it out to all the tissues, and then brings it back to the heart to pick up some more oxygen, blow off the CO2. All right, so we're going to talk about history and physical. History and physical is really important, just like when we talked about with respiratory system. So it is important to note things in their history, such as, do they have any history of congenital heart disease? Were they born with a PDA, a PFO, an ASD, a VSD, those things that we're going to talk about? Is there any significant family history of heart issues? And other important things that are going to be red flags that we don't think are related to heart, but are things like difficulty in feeding and not able to keep up with peers, those type of things, or failure to thrive. Just like with the lungs, their drive to have their heart beat is going to be higher for them wanting to eat. So if eating becomes too much of a demand on their body, they just stop eating, okay? It's always about supply and demand. And we're going to have a blood supply, all right? And we have a demand on our body. And when those are pretty equal. And we have the demands, you know, we have slight demands when we exercise, when we, again, walk up those stairs or whatever. We have a little demand. We have enough supply to meet those demands. But when we think about these kids with congenital heart defects, or even acquired heart defect, their supply is down here. So if they do put anything that puts demand on their heart, they can't get there, okay? So they're not going to do anything that puts a big demand on their heart because they can't. So eating is a huge demand on them. And so they tend to just not eat because it takes too much effort. So they tend to be failure to thrive. you'll see then that they'll be just more like lethargic kids, the scrawny kids, maybe pale in color. So you want to get that good history from the parents about what's going on, because those are going to be some of your first indicators that something's not right. When we look at physical exam, again, inspection and auscultation are going to be your two biggest parts of your physical exam. Yes, there's palpitation and percussion, but we don't use that as much. Inspection, we want to look at the kid. Do they look pale or cyanotic? Do they have any clubbing or spooning of the fingers? Do they look like they're just, weak or failure to thrive? And then when we're listening, obviously we're listening for normal heart sounds. Do they have a normal S1, S2? Or is there any kind of murmur? And then vital signs obviously are super important. Blood pressure. What is their blood pressure? And if we suspect a problem with cardiac, we do blood pressures on all four extremities, all right? One of the disease processes we're going to talk about, the way you diagnose it is because they have a blood pressure in the upper extremity that's different than the lower extremity. So if you suspect it all cardiac, you can't just examine one extremity and get a good assessment. You have to be able to do cap refill on all four, and a pulse on all four, and blood pressures on all four. All right. So if we do our history and our physical, and we're like, something's off, we may need to do diagnostics to confirm that something's going on with the cardiovascular system. So we'll do a chest x-ray or an EKG or an echocardiogram. Those three things are non-invasive. So a chest x-ray shows us basically just a picture of the heart, the shape of it. An EKG shows the electrical activity of a heart, and the echo is going to give us a better 3D picture of the heart, shows us valves and those type of things. They're non-invasive, but we still have to do patient teaching, because when you stick little electrodes on a child, they think you're going to electrocute them, okay? So you have to educate the family. This is just a picture. This just measures how your heart is beating. This will not shock you. It will not hurt you. You will have little stickers on you. We'll take the little stickers off. So they're non-invasive. They're pretty easy. You don't have to do a lot. But remember, they're kids, and they can be very literal at times. And when you say electrodes, that's a scary word to them. So make sure we're educating them. There's not a lot of post-op care with this, right? Cardiac caths, on the other hand, do have a little bit more oomph, a little bit more pre-op and post-op. Cardiac caths can be both diagnostic and they can be treatments. So we're going to educate the parents and the patient and their developmental terms on what they're getting the cardiac cath for, why they're getting it, and what it's going to do. Is it just going to help diagnose something, or is it going to also diagnose it and treat it at the same time? We just don't send everybody down for a cardiac cath. We have to make sure that they don't have what? This is all review, right? What? Allergies, right? Allergies to the dye. And so we know, because all of this that I'm talking about right now is all review. God, you guys are really not into it tonight. Is things, they're allergic to the dye, iodine, shellfish, those type of things. It is your job to make sure that they have consent signed and that they have documented that they don't have any allergies. In addition, we typically do a cardiac cath through the femoral artery, all right? That's your most common site. And for kids that are younger, what are they wearing? Diapers, right? There's a lot of funk that happens in those diapers, all right? They are all sorts of rashes and everything else. Again, it is your job to check that, because you will never have an angrier surgeon than one that gets down there and they realize they have a candidal, diaper rash, and now they can't do the procedure because the consent is signed for femoral and they just can't switch sites, and now the parent who's working, they can't get a hold of, okay? So, and it happens all the time. So we have to make sure that the site is nice and clear, that there are no diaper rashes or anything for the kid. And then we really have to educate the parents for post-op, because post-op, those kids, what does your cath patients do? They have to lay completely flat, right? With like a sandbag or something heavy on the site for pressure. How many people think that a child is going to be completely compliant with that? That kid's going to throw that thing off. It's going to be like, why can't I get up and play? I feel fine, as it's bleeding out. So, really educating the parents and saying, we're going to need to have something that's going to distract the kid. What's their favorite toy? What will keep them occupied and make them lay flat? Because they aren't just going to be as compliant. I mean, we have a hard enough time with adults being compliant, right? So imagine a little kid who all they want to do is get up and play. So cardiac cath is definitely more invasive, and we need to make sure that we do really good teaching in general for our diagnostics, but especially for the cardiac cath, which is pretty invasive. And then in general, we're just going to be noting our differences with kids. And remember, in general, kids are just more sensitive to volume changes. So, like I said, we have a supply and a demand. And when we have demands on our body, our supply can meet that. But kids are a little bit more sensitive to those changes. They have little reserve, and their oxygen requirements are higher because their metabolic rate is so high. So we need to keep that in mind when we're talking about the heart in general. I didn't write all that up there because I figured this is all review, and you could write what maybe you didn't remember, or like note to self, I need to review this. But that's just the heart in general. So now we're going to be talking about our specific cardiac congenital defects. But first, we got to look at fetal circulation. So how does blood pump through the heart in utero? And I just think that the human body is so freaking cool. The things that we are able to do, and even just growing a baby inside, a mother, it's pretty amazing. So we discussed how a normal heart gets oxygen, right? It has deoxygenated blood that sends it to the pulmonary arteries and to the lungs to pick up oxygen. Is that happening in utero? No, they're not taking any breaths, right? And they don't have air in their lungs. They have what? Yep, amniotic fluid in their lungs. So they're not getting it from there. So where are they getting the oxygen from? Mom, how? Yeah? You guys remember from level 2. So they get from the placenta, the umbilical vein, and I just call it red blood. It's not really like red and blue, but we're just going to go with that. So the umbilical vein from the mom, from the placenta, gives us oxygenated blood. Sends it to the baby's liver. And the liver keeps some of it and sends the rest to the inferior vena cava via the ductus venus. So that's a little off from what we've already learned, right? Because normally deoxygenated blood comes from the body. But the liver is sending that oxygenated blood through the inferior vena cava. All right, so But because deoxygenated blood is still coming from the body, the superior vena cava, there is a mixing of oxygenated and deoxygenated blood. So we get purple, right? Kind of a partially oxygenated. And again, it's not really purple, but your primary colors, red plus blue equals purple. Everybody remember that? My kid asks me all the time. He's like, Mom, what color does this and this make? I'm like, I don't know. I know. Or, Mom, how do I make this color? I'm like, I don't know. So, again, now it follows the normal path. So we have this mixing of blood. It goes to the right atrium and heads to the right ventricle. And it goes to the pulmonary arteries because it wants to head to the lungs, just like normal. But those lungs are filled with fluid. So it's trying to head out to the lungs, but as soon as it goes there, the lungs are filled with fluid, so it can't pass through those capillaries. So the pressure in the pulmonary artery is high, so you have increased resistance, increased pulmonary vascular resistance. All right? So it's trying to follow along the path, It's going up the pulmonary arteries. It starts to hit, but the lungs are like, nope, you can't go to us. We're filled with fluid. You can't go. So the body's kind of like, but that's the path we're supposed to go. So what do we do now? So that pressure in the pulmonary artery side, it increases the pulmonary vascular resistance, so there's decreased blood flow to the lungs. But that blood has to go somewhere. How does it get back out to the body? That's where we get these little pop-up valves that I like to call. You don't have to write the top. It's the same thing as the bottom. So the first little, what I like to call a pop-off valve, is the PFO. So, right here. It is between the right atrium and the left atrium. So if we were to look at a heart, you know, you've got the heart like this, right? And it's basically 4 sections. Your PFO is a hole right there. Everyone kind of see that? So it allows blood to be mixed from the right atrium to the left atrium. So it meets that resistance. The blood's like, I want to go. The lungs say, no way. And everything starts backing up. All right? That's normally what causes heart failure. But we don't want babies to have heart failure, and they don't have heart failure, because as it backs up, it just says, all right, we'll push that partially oxygenated blood into the left atrium. That's going to dump into the left ventricle to go out to the body. But that's not enough. We kind of need another little pop-up valve, and that's where your ductus arteriosus comes into play. So you see this little channel right here in between the pulmonary arteries and the aorta. So again, normally you would have blood heading out to the lungs, but the lungs say no way, so it starts backing up, but then it can also pop right here into the aorta. And what is the aorta feeding? The body. Wow, you guys really need like a coffee on break, okay? So we totally end up bypassing the lungs, and we can do that because we have these 2 little openings that are allowing blood to still get to the left side of the heart and get out to the body. And because we have such high pulmonary resistance, we have very little systemic resistance. And everybody likes to take the path of least resistance, right? You guys will read as little as you need to, or listen as little as you need to, or, I mean, it's human nature for us to do the path of least resistance. Same with the body. It's always going to take the path of least resistance. And the path of least resistance is sending blood out to the body, because the body's like, give it to me. Where the lungs are like, we're full, you know, no vacancy. So the high pulmonary resistance is causing the backflow, but it's allowing for easy systemic. So what happens at birth is when a baby is born, and that's why we like vaginal deliveries, because the baby kind of gets squeegeed through the vaginal canal, right? And they get pushed through, and all that fluid in their lungs kind of gets squished out. So they get all the fluid squished out, they take a breath, that ductus arteriosus and that PFO will close, and normal circulation resumes. Yeah?
So if a baby's born with pulmonary hypertension, it's because that exchange didn't happen at birth?
We're going to get there. Just hold that thought.
What does the top right say?
At birth, the lung, you take air in, so you decrease your pulmonary resistance. So as soon as the lung is filled with air, now do we still have this resistance pushing back on us? No. So now blood flow can resume normal. You hit the pulmonary arteries, and now it can go to the lungs because they've taken that deep breath. Your ductus arteriosus and your PFO close, and circulation resumes as normal. Now, the left side of the heart is the larger side of the heart, right? It's pumping blood to the body. It works a little harder. So the pressure in the left side is always higher than the right side. And we're talking about that path of least resistance. So a lot of times, if you have a defect, or, even with this, like the right to, you're going to have a shunting, a left to right shunt. And we're going to talk about that as we talk about some of these congenital defects. Does that make sense to everybody? I think it's pretty darn cool. I guess I'm the only one. The enthusiasm in here is overwhelming. If you guys, we have the Khan Academy videos, I think, in the course, and even if we don't, the Khan Academy videos are great, and they will walk you through it. So all the things we're talking about, they are some really good. The KAHN, Khan Academy. So if you have not explored that site, I use it for everything. I use it to do my child's algebra homework with her because I can't figure it out. All right. So when we talk about congenital heart defects, we're going to be talking about acyanotic heart defects and cyanotic heart defects. So I'm going to zoom ahead for a second. Nobody freak out because I'm going to talk about all of it. It's all right. I'm just going to put them all together. I know. All right, everyone take a breath. Ready, and go. So I put these three on here because basically they're all the same. Essentially, they all cause the same problem. All three of these are acyanotic congenital heart defects, CHD. So these babies, they come out pink. They look pretty good. There is basically increased pulmonary flow with these defects. The increased pulmonary flow happens because of that left to right shunt. So you have some kind of defect that is allowing more blood to head back to the pulmonary system than we would like, okay? And those defects are either an atrial septal defect, a ventricular septal defect, or a patent ductus arteriosus. All right. So, bless you. So we talked about the heart, okay? And it's got the four chambers, the atrium and the ventricles. Basically, your ASD is just that, atrial septal. The septum is the wall or the muscle that divides the two atrium. So an ASD, atrial septal defect, is a defect in that atrial wall. Does that sound just like the PFO that we needed in birth? Yep. So it's basically that PFO that didn't close like it should have when the baby took its first breath. Now, I drew a really big hole. It could be just like apparently I can't do a little hole. It can be a little pinpoint hole, or it can be the whole atrium. So it's along a continuum. Obviously, the bigger the hole, the worse the problems are because it's allowing more mixing of oxygenated and deoxygenated blood. All right? So with an ASD, as blood in the left atrium should go to the left ventricle, it gets shunted because of that left to right shunt, because of that pressure, back into the right atrium. So now you have partially oxygenated blood heading to the right ventricle and heading back to the lungs. So it would be like, and it's not all going there. And again, the bigger the hole, the more oxygen or the more oxygenated blood being shunted over. The VSD is the same exact thing, except for now the hole is in the ventricle wall. So again, septum is what divides the two ventricles. So a VSD is a ventricle septal defect. Again, it can be a small little pinpoint hole, or it can be the entire septal wall. The bigger the hole, the worse the symptoms. Because again, you're going to have a left to right shunt, and you have oxygenated blood mixing with deoxygenated blood heading back into the pulmonary system. That's your increased pulmonary flow. Your PDA is that ductus arteriosus that we relied on in utero to keep the baby alive. And for whatever reason, when the baby took its breath, it didn't close. So, blood coming from the aorta that should be going out to the body ends up mixing and being pushed into the pulmonary arteries to head back to the lung. So again, I know this doesn't look left to right, but again, the aorta is considered the left side of the heart, the pulmonary arteries are the right. So you have that left to right shunt, because that's where pressure is higher, is in that left side, and it's shunting oxygenated blood, sending it back, increasing pulmonary flow. So clinical manifestations are going to be exactly the same, and they're going to be exactly the same for pretty much any kid with a heart problem, okay? Because it's all about that supply and demand and their cardiac output and how it's happening. So if it's a teeny tiny pinpoint hole, they may have no symptoms. You may not even know it. You might just find it by accident because you might hear a little murmur. Or they might, and sometimes that murmur you might only hear when they're sick, because when they're sick, their heart has to work a little harder, but when they're well, they're totally fine. So it could be totally asymptomatic if it's small, maybe a little murmur. But if it's large, and we have a large amount of shunting, then all that stuff that I talked about, poor growth, dyspnea, retractions, is going to happen. Because the demand on their body to eat is too much because of their supply. They have limited supply. So they're not going to eat and they're going to have poor growth. And obviously, if we have increased pulmonary flow, it's going to be harder for our lungs to work. That's why they have the dyspnea and the retractions. So it's easy to figure out their clinical manifestations when we know exactly what's going on. We don't even have to guess. Treatment for both the ASD and the VSD is exactly the same. We basically hope that it closes spontaneously. We want it to close spontaneously. And most of them do close spontaneously. So if we find an ASD or VSD early on, we will sit on it and watch it until they're at least a year of age, because we don't want to do heart surgery on kids. If it's pretty big, and it doesn't close on itself, or if it's causing the child to be, really symptomatic, like the really poor growth, then we'll go in and we'll either close it up or put a patch there. But remember, that's now causing scar tissue, and you're putting something foreign into the body. So these children are always going to be at risk of developing a bacterial endocarditis, which we'll talk about towards the end, but basically an infection of the heart. So anytime they have surgery, dental work, anything that increases the chance that bacteria is going to enter that bloodstream, they need to be on prophylactic antibiotics. Because if they're not, and they get a bacteria in their bloodstream, the first place that bacteria is going to lodge is on something foreign or scar tissue. And if that's in your heart, which all the blood in your body has to pump through, just in case you didn't know, that's when they're going to get an infection. PDA is the only one that's treated a little differently, and I don't know why it's way down here, but it is. And we treat that with indomethacin. Indomethacin is a drug that they get one time, right after birth to try to help close that PDA. If for whatever reason they don't find it until later on in life, or the child is symptomatic and they have to do surgery on the PDA, then what they do to close it off is they actually just either tie a string around this and ligate it, or surgically cut it. Mm-hmm.
So ASD and VSD, if the child has the infection, then you do the prophylaxis for both of them?
Anytime a child has heart surgery, they need prophylaxis. Anytime. Because anytime you operate on the heart, you're going to either cause scar tissue or you're putting a patch in there or something foreign, and that puts them at risk for that bacterial endocarditis. Because if bacteria enter the bloodstream, the first place bacteria want to lodge themselves is on anything foreign or scar tissue. And so obviously then they're going to develop an infection of the heart. So anytime they have surgery, if they've had surgery on their heart, and that's where your history and physical would become very important, because you would say, you know, does your child have any congenital heart defects? Were they ever operated on? Because now if they're there because of a different operation, you would want to make sure you stop and say, oh, we need to make sure you don't need antibiotics before, you know, going any further. Because I've seen it. I've seen kids come in for a simple procedure like a tonsillectomy and end up in the ICU. And that seems silly, you know, because we could have prevented it had we just asked the right questions. All right. So those are your I group them together because those are your acyanotic heart defects that increase pulmonary flow. Your other acyanotic heart defect that we're going to talk about is coarctation of the aorta. And this does not increase pulmonary flow. It's an obstruction of blood flow. So there is a narrowing or a constriction of the aorta. So do you see right here, this kind of sausage-like area? It literally looks like a sausage casing. You know, like at a butcher. I'm sorry if you're a vegan or a vegetarian. Yeah. But it looks like a little like bunch of sausage casings. And we diagnose it either by echo. So the echo is a picture of it. It can be diagnosed and treated with a cardiac cath. So here our cardiac cath would be a diagnostic tool and a treatment tool. And these kids aren't usually symptomatic at birth. So they're not diagnosed until at least a week later. I have had kids, adolescents, get diagnosed with it. Because, again, it's all about supply and demand. And so what's happening is that the left side of the heart, the left ventricle pumps out the blood to the aorta, and the aorta is trying to get it out to the body. But it hits this constriction. Now this constriction, like this, let's say this would be normal, it could be just a little constricted, or it can be severely constricted. So obviously the greater the constriction, the more symptoms they're going to have. So if it is just a mild constriction, they might not see it at first. The kid that I took care of, he was entering high school and he wanted to start playing sports. And his own words, had been a pretty lazy kid up until then. And so he never had many demands on his heart. So he said, he was a little overweight. He didn't feel good about himself. He wanted to start getting into sports. So he started playing, and when he would play, he would complain that he would feel dizzy, and he thought he was just out of shape for a while. But what made his mom bring him in was because he would complain that his legs would always get like a tingling sensation when he would try to play. And that's because he had a supply, and his demands were never really that high. So his demands were here, and he could meet them. But now all of a sudden, he's older, and his demands greatly increased, and his left side of the heart's trying to really push to meet that demand, and it can't because of the constriction. So when we look at this, I'm trying to do it on here, so when you re-listen to it, if you re-listen to it. So we look at these branches right here. These three branches branch off to the head and upper extremities. So when it's pumping blood, the left ventricle is like, ooh, I got to really pump hard to get past this constriction. So it pumps really hard, and it forcefully pushes blood up to the head and the upper extremities. So they get dizzy, and they don't feel great, and they get a headache, and sometimes even nosebleeds. And their upper extremities are pounding in high blood pressures and pulses. But the amount of blood getting past the constriction is not as much. So everything below the neck is lower. So lower blood pressure, lower pulses. That's why he would get the numbness and the tingling. So when we look at it, everything above the area of the constriction is high. And that's where taking a blood pressure in all four extremities would be extremely important for a kid that we suspect of coart or that we know who has a coart. And everything below the level of the constriction is going to be low. A lower blood pressure, lower pulses, coolness, numbness, tingling. Oh, here they all are. Sorry. You're welcome. So, higher blood pressure for the upper extremities. They might have some poor growth, congestive heart failure, but really you're looking at, they might be a little dizzy, they might have lower pain numbness or coolness, they might get a headache or nosebleeds. So we may diagnose it at, very soon after birth, or maybe with one of their early well child checks. We might do blood pressures in upper and lower extremities and notice a difference. Typically, it's greater than a 10 mercury difference, okay? So that, let's say the upper extremities, 90 systolic and lower is 60. That would be a concern for us. So, or they get older and they put more demands on their body, which make the symptoms more obvious. So we're going to teach these patients to monitor their blood pressures and pulses frequently because we want to monitor for any changes. We can treat two ways. We can treat non-surgically with a balloon angioplasty. And basically with a balloon angioplasty, they're going to do a cardiac cath and they're going to insert a wire up. And the wire's got a deflated balloon around it. And once it gets to the area of the coart, they inflate the balloon and basically push open the vessel. All right? Sometimes that works great, and they do it once, and it keeps the vessel open. Sometimes, because it's like scar tissue and it doesn't work as well, they go in there and they open it up, and then it will eventually reconstrict. And so that they have to go back in there and open it up. That's why it's so important to teach the family about monitoring blood pressures and pulses. Because who is going to be taking care of these cardiac kids most of the time? The parents, right? They come to us when they're sick, but the people that are monitoring them for big changes and who can prevent them from getting seriously ill are the parents. So if they have a balloon angioplasty, one of the big discharge instructions we're going to tell them is, hey, you need to make sure you go home and just like we talked about, peak flow meters are going to be what help keep an asthma person, on track and know how to guide them. Monitoring their blood pressures and pulses are going to help keep a kid with coart. Yep, you're good. Your pulses, your blood pressures are within normal limit. Or wait a minute, we're seeing some bigger differences. We're noticing some trends. We need to get in to see the doctor sooner. If the balloon angioplasty doesn't work, then we can do surgical. Or if it's a really bad constriction where they don't think the balloon angioplasty is going to work, they can do surgery. And basically surgery is they just cut out the defect itself. So they're going to go in there and they're going to cut above it. They're going to cut above it and below it. And then they're going to take those two healthy pieces and do what's called reastomose them. Okay? So they're going to take out that constricted part, cut it, and take the two nice big healthy pieces and reastomose. Again, we've done surgery on them. They have scar tissue, so they're going to need to be on prophylactic antibiotics to make sure that they don't develop an infective endocarditis. Any questions? We good? All right. So those are your acyanotic. You have 3 that are increased pulmonary flow, 1 is an obstruction. And it's basically obstructing to the lower extremities. So you're looking for that difference. All right. So now we're going to talk about cyanotic. And the first cyanotic one we're going to talk about is tautology of flow. And unlike our acyanotic ones where we had increased pulmonary flow, this one has decreased pulmonary flow. These are your blue babies. They come out blue. And tautology is basically 4, right? So there's 4 defects. And flow is just that dude that found them. So there's nothing special about that word. And because of these 4 abnormalities, you have decreased oxygenated blood that's pumped to the body. The first defect is pulmonary stenosis. So that pulmonic valve right there that should be receiving blood from the right ventricle should be nice and like flappy, right? It should just be like ready to take it on, all right? But it's all stenotic, meaning it's like hard and sticky and it's like, right, trying to open up. So because of that pulmonic stenosis, and it's really just kind of really hard to get blood into the pulmonary arteries, that right side of the heart has to work really hard. So you have right ventricular hypertrophy. Okay? So the right side of the muscle has to work really hard to get blood past that pulmonary or pulmonic valve. Now, normally we like muscles, right? That's why we work out. What's that song? I work out, right? To get big muscles. But we don't like big muscles in the heart because when we have big muscles in the heart, it decreases the amount of volume of blood you can have in that chamber. So, if this is my heart, okay, and I can normally, and I'm making this number up, have 10 mLs of blood in here, and you're like, oh, all this blood, right? Yay, a lot of blood in the chamber. But now, because of hypertrophy, my muscle is all thick. It takes up space, right? So now I can only get like 5 mLs of blood. So I can't get the same amount of volume out, and I'm having a hard time even getting that volume out because I'm pushing against this stenotic valve. All right? Now remember I said it's all about supply and demand and cardiac output. Cardiac output is the amount of oxygenated blood going out to your, body. If I don't have the normal 4 to 6 liters going out, that means that my tissues aren't getting the amount of oxygenated blood it needs to function. So if my brain's not getting the amount of oxygenated blood to function, I'm going to be confused and agitated and irritable, right? If my lungs aren't getting the amount of blood they need to function, it's going to be hard for me to breathe. I'm going to be short of breath. If my skin is not getting the blood that I need, I'm going to be cool and clammy. If, my GI system doesn't get the blood it needs, it's going to shut down. That's going to happen for no matter. So everyone freaks out about the heart, but honestly, the end game of the heart is always the same. Low cardiac output, supply and demand, okay? So the third thing that's happening is an overriding aorta. So where should the aorta be feeding from? The left ventricle, yeah. And if you didn't know that right off the hand, that's what I'm talking about. You guys really need to be able to tell me where they're all coming from. So the aorta should be feeding from that left ventricle, and it should be feeding oxygenated blood to the body. But it's overriding, meaning it's sitting over both the left ventricle and the right ventricle. And that's happening because of this VSD, that ventricle septal defect. So because I have a hole in the septum, it allows mixing of blood, and the aorta is pulling blood from both the left ventricle and the right ventricle. That's why they're blue, because they're not really getting fully oxygenated blood. They can barely get enough blood to the pulmonary arteries to pick up oxygen, and the blood that they can get to pick up oxygen is being mixed with deoxygenated blood and being sent out. So, their clinical manifestations, they start off with some mild cyanosis and can develop acute cyanosis. They have a murmur and polycythemia. So again, just like when we were talking about COPD and we were talking about chronic bronchitis, remember that body's in that chronic hypoxic state. God bless you. So the bone marrow doesn't know why we're chronically hypoxic. The bone marrow just knows that its job is to produce red blood cells. So the body's hypoxic because of the 4 defects. So it doesn't matter how much oxygen I throw at this baby. Oxygen's not going to make it better because the baby still can't get blood to the lungs to pick up that oxygen. So you can throw all the oxygen you want at the baby, it's not going to help. All right? That's why you really need to understand what's going on, because this is where NCLEX tries to trick you and say, what would be the first thing you would do for a baby, with tetralogy of Fallot? And one of the options would be oxygen. And you guys would be like, yeah. And it would be no, okay? Because it's not going to help this baby. And they develop that polycythemia because the bone marrow is saying, oh, I just need more red blood cells, because red blood cells have hemoglobin, and hemoglobin carries oxygen. And so if I have more red blood cells, I can carry more oxygen. But nope, I don't need it. So all I do is increase my crit, right? Because your hematocrit is the amount of red blood cells compared to the volume of blood. So now I have a lot more red blood cells in comparison to volume, and that gives me that polycythemia.
What does the polycythemia do?
So these babies are known to have what we call TET spells, all right? And this is an acute episode of cyanosis and hypoxia. And what's happening is, again, remember, it's all that supply and demand. This baby's supply is minimal. They don't have a lot of supply. So they can barely meet minimal demands, barely meet their food requirements, barely meet just normal. So anytime a demand is put on them, they can't meet it with their supply. So they get pissed off because they have the wrong color spoon, or mom tells them no, they can't have that ice cream, or they're crying because, ouch, that hurt. That's all, huge demands on their body, and they develop this TET spell where they turn blue, like bright blue around the lips, toes and fingers go blue. They get severely hypoxic because their O2 requirements are much more than their supply, okay? And so what we need to do is increase systemic resistance, all right? And we're gonna talk about that in just a second when we talk about treatment. So they get diagnosed with, obviously, clinical manifestations. They're blue. A lot of times we can diagnose this in utero. They know that something's going on, or the baby's born, and the baby just, has failure to thrive, is not quite, growing and feeding the way they should, is always a little blue tint. We get them diagnosed through clinical manifestations, and then we confirm it with things like a chest x-ray. Because of the big right ventricle, their heart looks like a boot. And I'll show you that in just a second. The echo is going to show us, the stenotic pulmonic valve, the VSD, the overriding aorta. And a cardiac cath is also going to help diagnose it. But for treatment, it's going to be surgical repair. All right? They're going to try to do it in one fell swoop. Oftentimes they have to do a couple of steps, because what they'll have to do is go in, and the first thing they're going to do is move the aortic valve over, okay? And then they have to go in and close the septum back up. And then maybe they can go in there and kind of make the valve, replace the valve so that it works better. They really can't do anything about the hypertrophy. Once it's there, it's there. So we want to catch it and treat it sooner versus later so that there's minimal long-term damage. But, because obviously these kids can develop heart failure. They're at risk for congestive heart failure post-op. And again, it's because of that low cardiac output. And we know the signs of low cardiac output. You guys know it. I think you freak out and you want to memorize all these clinical manifestations. Honestly, they all are exactly the same. It's just, think about your organ. What is your organ supposed to do? If it doesn't have the oxygenated blood it needs, it's not going to do that. It's going to do the opposite. And then when the kid does have one of these TET spells, while they're waiting to get repaired, we need to increase systemic resistance. Because remember I said the body is always going to take the path of least resistance. And so, sometimes we have a little baby in here. No, we don't. So you'll see, it's actually kind of cute. Like the kids who can walk, you'll see them, they'll be playing and all of a sudden they just go like this. All right, they just squat down. What that does is if I bring my legs up, my heart would have to work harder to pump blood to my legs, right? It would, because it's increasing the resistance in my systemic system. So when I'm like this, I know it seems kind of weird because it's more, but it's easy flow, right? When my heart pumps, it's easy for the blood to get to my body. But if I am in a squatting position, I'm now increasing my systemic resistance, decreasing my pulmonary resistance. That makes it easier for blood to go back to the lungs to pick up oxygen so that I'm no longer a blue baby. All right? You have to tell parents how to do this because every time their baby cries, they're going to have to shove that baby's legs up and make sure that we do this. So obviously a little infant's not going to know to do it, but the parents will know that when the baby cries, they're going to have a TET spell and they're going to lift the legs up to increase systemic resistance, to decrease pulmonary resistance, to try to get more oxygen and decrease the cyanotic event. And this is really hard because you have to tell a kid no. You have to provide some discipline. It's hard to not have an infant cry. And if they're crying because they're hungry but they're too tired to eat, that's very frustrating. So there's a lot of education and a lot of support that needs to go into this because our job is to really minimize upset for the child because the more upset they are, the more likely they are to have a TET spell, right? And more damage or possibly even death from it. But at the same time, we're trying to do all these things that you're like, Dr. D, you've been lecturing me about Erickson and trust versus mistrust. And how do we develop that if, we're just giving them everything they want? So a lot of parents find it very frustrating because they still need to let their kid be a kid and they still need to create boundaries. But when they're sick, it's like, I don't really care. They could eat ice cream every meal. They're just not going to die. That's what I care about. So it's really hard to educate them about parenting practices or expectations when they're just worried their kid's going to, not make it. All right. So minimize upset to decrease TET spells. And then this is where you can see the boot shape right here. You see, I'll do it on here. So you see right here where it looks like a boot right there. Normally your heart would come like here and it would be like here. So, and this is what a TET spell looks like. Blue, blue baby. All right. I'm going to do the last two cyanotic ones real quick because they're pretty simple. And I'm going to put them both up here, so don't freak out. So, the first one is transposition of the great vessels. And basically, there is no communication between the pulmonary and systemic circulation. So remember, normal is right here on this left side. My right atrium feeds deoxygenated blood to my right ventricle. It goes to the pulmonary arteries. It comes back to my left atrium, left ventricle, aorta. Okay? What happens here in transposition is your aorta is feeding from your right ventricle, and your pulmonary arteries are feeding from your left ventricle. So you have oxygenated blood going to your lungs, coming back to your heart, going out to your lungs, coming back to your heart, going to your lungs. So you just have a loop of oxygenated blood between your heart and lungs. And then on the other side, you have a loop of deoxygenated blood going to your body, coming to the heart, going to your body, going to the heart, coming to your body. You don't have mixing. So remember, normally we want blood flow to do this, right? Interact. There are two systems that interact with each other. It's important for them to interact. With transposition of the great vessels, you have pulmonary doing its thing, and you have cardiac doing its thing. And it's kind of like a wax on, wax off.
Giving a baby, that's the biggest one.
Oh, yeah. So a wax on, wax off. Those systems are not interacting at all. These babies are diagnosed very quickly because they are getting zero oxygen. So they are blue. And they will 100% die on you if you don't fix them fast. They are severely cyanotic. They have no improvements with oxygen, and they're very tachypnic. So again, this is where NCLEX will trick you. It's going to say, baby X was born, APGARs are 1 in 1, or whatever the lowest can be. We suspect transposition of the great vessels. Nurse's priority action is to A, give oxygen, B, give prostaglandin, C, give indomethacin, D, call the physician. And you guys are going to think, oh, they're not, their APGARs are low, I need to give oxygen. It's not going to do anything for this baby. You could give them 100%, you could intubate them and give them oxygen. It doesn't matter because they're just two systems working on their own. So those defects that we talked about, the PFO, which is the ASD, and the PDA, the patent ductus arteriosus, we need those defects in order to keep the baby alive. So before we're looking to close it, what is that? I know, well, apparently they enjoy their class, not you guys. I must be doing something totally wrong. So, we need those defects. If we do not have those defects to mix the blood, the baby will die. Because we can't get him into surgery fast enough. So in order to do that, we give prostaglandin E. It's just it's typically a normal heart sound because it's still beating. It's just not they're not interacting. These babies are super sick. I mean, they are blue. They're gonna die. Everything is blue. They're getting zero oxygen. Zero. Yep. They're not. They breathe. They breathe just fine. But it's because the vessels they're just doing their own thing. So the baby's breathing. Oxygen's getting in the lungs, but remember, what do we do with that oxygen that's in the lungs? No, the oxygen goes into those capillaries to go to the heart, correct? But what's happening is that it's supposed to go to the heart and be fed out to the body to be used. Instead of being fed out to the body, it's coming right back to the lungs. So they're just picking up more and more oxygen. That's it. Mm-hmm. Right away. I mean, because as soon as the baby takes a breath, they're no longer getting oxygenated blood because in utero, we bypass the lungs anyway. So it's okay in utero, but when they're born, their lungs are supposed to initiate, and that's how they get their oxygen. And they're not getting it. So a lot of times we know this is happening in utero, so we're ready. There's a code team there. They come, they have the prostaglandin on site to keep things open. And then they go ahead and start prepping the baby for surgery. And they're basically just going to swap the vessels and put them in the right spot.
I have a question.
Mm-hmm.
So you said the prostaglandin keeps the tube open.
It definitely keeps the PDA open.
But isn't it already? Well, obviously when the baby takes the first breath, it's going to close. but all of this is happening even though it's open, I guess? Because it's already open, but it's all happening.
So when a baby takes its first breath, it's not like you take a breath and it goes and it closes right away. It starts to close with its first couple of breaths, okay?
So you're just gonna keep it open to
Yeah,
prevent it
so-
from happening quicker.
Well, you can't prevent that the vessels are feeding from the right spot with the prostaglandin. The prostaglandin has nothing to do with the vessels being fed. What the prostaglandin does is keep the PDA open so that you have mixing. Because you see right here, you have deoxygenated blood going to the body and coming right back here.
Mm-hmm.
So you never get oxygen going to the body. In order to get oxygen, you would have to have that PFO right there and that PDA right here, which it's not showing on this picture, but you would want. And with that mixing of blood, the baby's gonna get some oxygen,
Okay.
but not enough to sustain life for a long period of time. So they give the medicine so that we can sustain life just
Just a
enough
little bit longer.
to get
Okay.
them into surgery.
Got it.
Yep.
Got it.
All right. Everybody good with that? And the last one is your hypoplastic left heart. So you can see right here, you see the right ventricle, and then the left ventricle is tiny. All right? So basically, you have an underdeveloped left ventricle. And again, we talked about this is, let's say this is the normal left ventricle. That's the chamber. And a normal left ventricle can hold, which I'm just making this number up, 10 mLs, okay? With hypoplastic left heart, you have a left ventricle that is this tiny. So it can only hold this much blood. Teeny tiny. It always reminds me of like Aladdin, where he's like, great cosmic powers, teeny tiny living space, right? Anybody watch Aladdin? No? Okay. That's what it makes me think of. The left ventricle is so small, it can't have enough blood. And basically, there's not enough cardiac output to sustain life. There's only this little amount of blood that can go in that left ventricle. And because it's such a thick muscular wall here, think about it, it can't really stretch and squeeze. So there's not a lot of blood, it can't really push out, so it's not enough to sustain life. It's often diagnosed in utero by echo, and these babies are sick as well. They come out, they're mildly cyanotic, right? But then they quickly develop congestive heart failure, especially when that PDA closes. They progress very fast and can even die. So again, we want to give them the prostaglandin because we want to keep that mixing of blood, because the prostaglandin is going to allow the oxygenated blood from the right atrium to be mixed with the left. And then also the PDA will allow mixing. And these babies, oftentimes they get put on a vent right away. They come out, they're sick. We know they're sick. These are the babies that are going right to the CVICU. They are getting vented, intubated, vented. They are going to have surgeries. It is a multi-step surgery. Have you guys gone to All Children's yet? Okay, so if you go to the CVICU, you might hear terms like Norwood 1, or in your readings you might see Norwood 1, Norwood 2. You don't need to know what's happening at each of these stages. You just need to know that they're sick babies, and that they are going to require several surgeries. They're typically in the hospital their entire first year or longer of life, and oftentimes the surgeries don't work, and they have to get a heart transplant. And the parents are aware of it from the time they're in utero, if they've done prenatal care. So I should say the majority of the time they're aware of it. vent, mechanical vent, surgical treatment, several stages, and then transplant. All right. Any questions about that? All right. So those are your acyanotic and cyanotic congenital heart defects. And so you really need to understand how blood flows and what's supposed to be where, because many of the congenital heart defects is just there's some kind of defects that's causing the blood to flow in the wrong way, or vessels are not where they're supposed to be. So if you understand the normal, you can figure out the abnormal.